The lower lid blepharoplasty has an infinitely greater number of variations than the upper lid blepharoplasty, and in essence the problems are simply that gravity isn't on your side, and any attempt to be too aggressive will either cause a rounding of the lateral canthus or frank ectropion, both of which will see you needing to perform revisionary surgery, but at the more extreme, either of which could see you being sued. So it's very important not to try and be too aggressive with the lower lid blepharoplasty, especially in trimming off excess skin. One of the key elements, therefore, is your preoperative consent, such that the patient understands the limitations of a lower lid blepharoplasty, and that the overall amount of skin that can be removed and the degree to which the lower lid can be improved is limited. I tend to suggest that if my patients are going to get 95% of what they would like with an upper lid blepharoplasty, then the chances are they're only going to get 70% with a lower lid blepharoplasty. Now, with your patient lying down, you can work out how much spare skin there is by either having them look up over the top of their heads or open their mouths. So at this point my patient is looking up over the top of his head, and I calculate just how much quite safely I can lift his lower lid, and after drawing in this first point, there's a significantly reduced amount of vertical skin then underneath the eye to avoid the risk of producing an ectropion. Again, with the patient looking up, I check that I can pinch the skin without causing any ectropion, and here again, by holding gently at the bottom, you can see how it's going to look if that much skin is trimmed off. Again, this is with the patient looking up. I now ask him to not look up, but to look straight ahead, but to open his mouth. And with the mouth wide open, there's perhaps even less spare than by looking up. If you ask your patients to both look up and open their mouth simultaneously, then you'll realize the ultimate limitation of what would seem to be excess skin on the lower lid. So here's with the mouth open and looking up, you see there's actually much less than you think. However, I find that if you ask the patient to either look up or open their mouth and base your measurements on one or other, then you'll be about right. This gentleman has opted for local anaesthetic, and this is slightly less fun for the patient than for an upper lid blepharoplasty, because for a significant portion of the surgery the eyes are open, and both the bright microscope light and of course the sight of the scalpel blade coming towards them is evident. The first part of the excision, I now use the scalpel. I find this gives me the nicest possible scar, even if I'm using cutting cautery later on. And the excision at this point doesn't need to be deep, it's essentially just through the skin. Coming a little deeper through the thicker skin more laterally. The next step is to use the cutting cautery to come deeper here, in this case under the skin and the orbicularis, to make a pocket into which the straight scissors will then be able to slide. And at this point it's safe to use the cutting cautery, as this isn't going to affect your skin scar. Having identified the plane, therefore, the spring scissors slide in and stretch. I beg your pardon, not the spring scissors, the straight scissors slide in and stretch. And now it's important to angle the scissors such that you leave some Orbicularis to help support the lower lid, and then change the angle again such that you're perpendicular to your excision for the lower portion. So the scissors are shelved on the upper excision and perpendicular on the lower, and this should give you a nice healthy piece of Orbicularis to help support the lower lid, as demonstrated just there. A little bit of cautery is then necessary at this point, but if your measurements are right, the skin should already be sitting in a much better position. The next step is to tighten the lower lid, and this is necessary in all but the youngest patients, but can be done quite elegantly simply by splinting the tarsus at the lateral canthus, picking it up with a double-armed 5/0 proline and supporting the lateral canthus to the orbital rim in exactly the same fashion as you would for a tarsal strip, but without actually the tarsal strip. In an older patient with increased lid laxity, you may indeed choose to proceed to a full tarsal strip in order to get an adequate lower lid tightening. These bites then pass, ensuring that the needle enters on the inner aspect of the orbital rim, and also ensuring that you don't change the height orientation of the lateral canthus. In order to keep the proline buried and comfortable, I then tie 5 knots, leaving the needles on, which is a little cumbersome, but enables you to then use the needle to pass the proline posteriorly. Here you see the first knot, first of the 5 knots, tightening up the lower lid, and then a further 4 knots are placed, but then using the proline needle, passing posteriorly and out through the skin, enables you to make sure that the proline ends are tucked flat, don't stick up, and are comfortable for the patient. And I find the ease of burying the proline ends by leaving the needles on is worth the difficulty in tying the knots with the needles on. The next step now is to anchor your lift, and for this you need to take a 5/0 vicryl and take a good bite of the periosteum, and if it's loose you need to recite it. This needs to be a good periosteal bite. And one way of checking you're solid is, once you've got your bite, you should actually be able to pull on the suture and cause the patient's entire head to move if need be, just like that. This solid bite then goes in a straight line towards the corner of the mouth, and at that point you pick up the suborbicularis oculi fascial layer, and typically a bite of the orbicularis at the same time, but the idea is to go to the layer just deep to the orbicularis, pick up a good bite, and check that this gives you exactly the shape lift you want, such that there'll be no tension on the skin once the skin's closed. The 5/0 vicryl is double armed, and the second bite is passed parallel to the first, and each of these bites are quite generous. Then again you check you're getting the lift you want, and this suture is locked in place. With both a Prolene and a 5/0 vicryl, post-operatively the lateral canthus often swells, and I warn the patients to expect this and to be prepared with their ice packs. So you're on the home straight now, and the lateral canthus picks up a single vicryl bite of an interrupted suture just to hold the skin and orbicularis at that position. And then I place another 6/0 vicryl into the orbicularis with the knot at the bottom. And this again helps support the skin. The aim is that the skin edges should be in apposition without any tension whatsoever in order to get the thinnest and most elegant scar. Occasionally, at this position, you can look at the skin and see that you've still got a little bit of overlapping skin, and the easiest way to trim this is to hold the apex and take the scalpel blade and pass first to the medial direction and then in the lateral direction, and just gently score the skin, and then take the scissors and trim that tiny little edge piece off. And all that now remains is to close the skin, and my preferred technique at the moment is to use a 6/0 Prolene in a running fashion without any knots. When I first started doing this, it seemed a little curious not to put a knot, but it seems to be very comfortable. It enables the suture to move should the lower lid swell excessively, and there's absolutely no risk of a knot being pulled in or buried by the swelling. And while for the first week the patients may feel self-conscious with a steri-strip holding the suture down at each end, I find that most of my patients feel quite self-conscious while the sutures are still in place anyway, and most of them tend to either stay indoors or venture out only with dark glasses on for the first week. The skin edges should be very nicely opposed. At this stage there's very little bruising, but this typically develops now together with the swelling over the next 2 to 3 days. The steri-strips are placed just holding each end of the Prolene suture down, and this Prolene suture is removed on day 6. I typically apply a Gelinet pad and some cold compresses for the next hour.